students, let us understand the concept of upper motor and the lower motor neuron first. So as we all know that the upper motor neuron, which arises from the cerebral cortex, it descends downwards up to the level of brainstem or the spinal cord. So that neuron is known as an upper motor neuron, and another neuron which starts from the spinal cord and it ends by innervating the peripheral muscles, so that is known as the lower motor neuron, that is LMN. Right, so that was very simple concept, that one neuron which arises from the cerebral cortex, it descends downwards. Let me write it over here, that origin is from the cerebral cortex, descend downward up to the level of brainstem or spinal cord, that is known as an upper motor neuron. Another neuron which starts from the spinal cord and it terminates by innervating the peripheral muscles, that is peripheral muscles, so that is the lower motor neuron. So very simple concept of upper motor and the lower motor neurons. Let us understand about the motor neuron diseases. So motor neuron diseases, these are the heterogeneous spectrum of inherited and the sporadic clinical disorders of upper motor neuron, lower motor neuron, or in combination of both. So here there are few subtypes of the motor neuron diseases. So first of all, you can see this, that is amyotrophic lateral sclerosis. So in which there is degeneration of the corticospinal tract. So corticospinal tracts, which starts from the motor cortex, ends in the spinal cord. So there is degeneration of this tract, degeneration of neurons of the motor cortex, degeneration of the neuron which are present in the brainstem, and the degeneration is also seen in the anterior horn cells of the spinal cord. So let me write it over here, the anterior horn cells of the spinal cord, then in the brainstem, then in the motor cortex, and the neurons of the corticospinal tract, commonly known as a pyramidal tract. Next subtype of MND, that is the primary lateral sclerosis, in which we see the degeneration of the upper motor neurons. Third one, that is the progressive bulbar palsy, in which there is degeneration of the neurons of cranial nerve, that is 9th cranial nerve and the 12th cranial nerve, namely the glossopharyngeal and the hypoglossal nerve. And the last subtype, that is progressive muscular atrophy, in which we see the degeneration occurring at the level of brainstem and the spinal cord. So let me write it over here, the degeneration which occurs at brainstem and spinal cord. And in this video, I am going to mainly discuss about the amyotrophic lateral sclerosis. Let us understand about the amyotrophic lateral sclerosis. So basically, ALS, it is characterized by degeneration and loss of motor neurons in the spinal cord, brainstem, and in the brain, resulting in variety of upper motor neuron and the lower motor neuron signs and symptoms. Now let us focus on the beginning of the disease. So in the beginning of the disease, there are main two types. First is which is developed by 70 to 80% of the patient, that is the limb onset ALS. Let me write it over here, that the first one, that is limb onset ALS, developed by 70 to 80% of the patient, and in which patients start showing symptoms in the limbs first. And the second one, that is the bulbar onset ALS, which is developed by 20 to 30% of the patient, in which bulbar muscle weakness, in which the patient shows the symptoms related with the bulbar muscles weakness. So that was all about the beginning of the disease. Now, epidemiological surveys have found that there are many known risk factors and possible risk factors behind the origin of the amyotrophic lateral sclerosis. So all those known and possible risk factors that you can see on your screen now, so they are basically responsible for the upper motor and the lower motor neuron symptoms. So as you can see that there are some known risk factors as well as the possible risk factors for the ALS. As we know that amyotrophic lateral sclerosis, it is a progressive disorder in which the motor neurons, they degenerate, and degeneration occurs at different sites. That is, motor neurons in the cerebral cortex as well as in the brainstem and in the spinal cord, they may be affected. So what happens is, if they are affected in the brain, in the motor cortex, so mainly the neurons of the corticospinal tracts, they are affected. If the cranial nerve nuclei are involved, then the cranial nerve nuclei, that is the trigeminal nerve, facial nerve, glossopharyngeal nerve, vagus and the hypoglossal nerve. These 5 nerves, they are mainly affected, and in the spinal cord we all know that is the anterior horn cells are affected in case of an ALS. Let us understand this thing with a very simple example. As we are discussing that the motor neurons degenerate or there is loss of motor neuron in the ALS. So suppose in this diagram number 1, suppose these are the motor neurons, there are multiple motor neurons, they innervate a typical structure. But in case of an ALS, what happens is the degeneration starts. So here is the degenerative process is going on. That is, degeneration in the motor neuron has started. So what happens is this typical muscle will be partially denervated because the full innervation is now somewhat lost. Now what happens is, in case of an ALS, the intact neurons which are adjacent to this degenerated neurons, so the axons of this intact neuron, they sprout and they innervate the partially denervated muscles. So this thing happens in the ALS, that the intact neurons will sprout and they innervate the partially denervated muscles. But in case of an ALS, there are some areas, or I can say there's some of the sites which are spared, that is the extraocular muscles. So extraocular muscles supplied by the cranial nerve, that is 3rd, 4th and 6th, they are usually spared. Second thing is the Onuf's nucleus. So Onuf's nucleus, which is situated at the ventral margin of the second sacral spinal segment and which controls the pelvic floor muscles, anal and the external urethral sphincters, that is usually spared. And the sensory symptoms, as we are discussing the motor neuron diseases, sensory symptoms may be very rare, and also the spinocerebellar tract degeneration is also very rare, and if they are affected up to a very lesser extent in comparison with the motor neuron degeneration. But few things that we need to know that, as I have mentioned earlier, that this motor neuron diseases, they are inherited as well as they are sporadic also. Inherited means there is family history is present, and sporadic means there is no family history. So in case of a family history, there are certain things which are very common, but it is very rare in the sporadic. So the first thing is degeneration of the spinocerebellar tract, which is very common in the familial ALS, but it is very rare in the sporadic ALS. And the second thing is the sensory symptoms. So the sensory symptoms and the posterior column degeneration, which is very common in the familial ALS, but it is rare in the sporadic ALS. So this differences we should know whenever we are assessing the patient with the motor neuron diseases. Now let us shift to the clinical features of the amyotrophic lateral sclerosis. Let us focus on the clinical features due to the lower motor neuron pathology. So as you can see that there are multiple clinical features. So the first is the focal or the asymmetrical weakness. Second thing is upper extremity, lower extremity or the bulbar muscle weakness can be seen. Next thing is the lower motor neuron loss causes more dysfunction than the upper motor neuron loss. For this, the initially isolated or the distal muscles are mainly affected. So let me write it over here, that isolated distal muscles. So distal muscles, they are mainly affected first, and with isolated muscles, right? And in this we must remember the point number 1, that is there can be focal asymmetrical weakness can be seen. The patient may complain of problem in the buttoning, pinching, writing, or the foot slapping. So it is not necessary that all the time you get the symptoms in the particular lower extremity or upper extremity. So there can be buttoning, pinching, writing, so that is the upper extremity isolated muscle weakness. That can be the focal and the asymmetrical, as well as the foot slapping, so which starts from the lower extremity also. Second thing is changes in the voice. So change in the voice, so which shows the bulbar onset. So changes in the voice. Next thing is the cervical extensor muscle weakness. So cervical extensor muscle weakness, so which is very common. Let me write it over here, that the C-spine extensor weakness. C-spine extensor weakness. So in this, usually this causes the patient problem in the ambulation as well as in the feeding activities. So cervical extensor weakness, which causes the head drop sign, right? And next thing is the shoulder subluxation. Shoulder is very much prone for subluxation. Let me write it over here, that the shoulder joint subluxation. Shoulder subluxation. Next thing is the Achilles tendon shortening. So that is, let me write it over here, that Achilles tendon shortening is seen. Claw hand, which is another important thing causing the dysfunction in the hand. Claw hand adhesive capsulitis, again one of the shoulder problem, that is adhesive capsulitis. Let me write it over on this side, adhesive capsulitis. In short, I write it as AC. And the posture and the balance affections. So as you can see that due to the lower motor neuron, there are various deformities as well as the impairments can be seen. So remember one thing, that it can be focal, asymmetrical, right, claw hand, problem in the buttoning, pinching, etc. These all are the activities which are seen in as a lower motor neuron pathology. Let us focus on the clinical features due to the upper motor neuron pathology. So because of the upper motor neuron, along with the hyperreflexia, spasticity, clonus, positive Babinski sign, one of the most important thing that we need to see in the patients as a physical therapist, check the gait pattern of the patient. That because of the upper motor neuron pathology, patient may show abnormalities in the swing phase of the gait. As you can see that I have drawn the swing phase, that is there are 3 phases, that is acceleration, mid swing and the deceleration. So because of this spasticity, patient may show abnormality in the swing phase of the gait. And another thing that we must include, that sometimes the patient complains of pain as well as the paresthesia like feeling. So the sources of the pain and the paresthesia like feeling is that because of spasticity or the contracture formation and the immobility, it may give rise to the pain. So all of this, that is spasticity, immobility, as well as the contracture or the deformity formation, right? So these all can give rise to the pain, and these all may be the sources of pain in the patient. But the detailed evaluation must be made by a physical therapist. As the ALS or the Amyotrophic Lateral Sclerosis, it is progressive in nature. It also affects the respiratory muscles also and give rise to the signs and symptoms of the respiratory systems also. So the first thing, that is the fatigue. As you can see over here, fatigue is the first symptom. Second thing is the dyspnea on exertion. frequent awakening at night, and the daytime sleepiness. So these are the very common recurrent sign. Morning headache, so let me write it over here, that patient may complain of morning headache. That is morning headache. Next thing is the truncated speech. Speech is also affected. That is truncated speech. Paradoxical breathing. So here we have ribs, and if we focus on the respiratory movements, so that is the paradoxical breathing is seen. Paradoxical breathing. Accessory muscle use. So accessory muscles located over here. So that is the accessory muscle use. And should I write it as an accessory muscle? Next thing is the vital capacity of less than 25 to 30% of the predicted, which indicates higher risk for the respiratory failure and death. So let me write it over here, that the vital capacity of the lungs. So here we have both the lungs. So vital capacity less than 25 to 30% of predicted. So which shows the increased risk of respiratory failure, and there is hypoxia, that is decreased amount of oxygen saturation. So these all are the symptoms are only due to the respiratory pathology. Now let us focus on some of the cognitive symptoms. Some of the cognitive impairments in case of an ALS, they are usually divided into two. That is the ALS associated frontotemporal dementia and the frontotemporal dementia without the ALS. So ALS, so first thing that is associated with the frontotemporal dementia. So as you can see that there are some of the clinical features, that is the executive function impairment. Second thing, that is the planning and the organization, concept abstraction, and the personality changes. They are usually seen in the ALS associated with the frontotemporal dementia. Now comes the ALS without the frontotemporal dementia, in which we see the difficulties in the verbal fluency. Second thing, that is language comprehension, memory, abstract reasoning, and the generalized decrease in the intellectual of the patient in the ALS without the frontotemporal dementia. And some of the rare impairments are also seen, which are now on your screen, that these are the very rare impairments. It includes some of the sensory impairments also, but these are very rare, not usually seen in case of an ALS. So because of the bulbar onset ALS, there are a few symptoms that we need to focus on. So in the bulbar problems, we divide it into two, that is the spastic bulbar palsy and the flaccid bulbar palsy. So in which typically the weakness of this many structures, so weakness of tongue, lips, jaw, larynx and pharynx, that is seen. And in case of an spastic bulbar palsy, we see dysarthria. In case of flaccid bulbar palsy, we also see dysarthria. But in case of spastic bulbar palsy, the voice sounds very forced, whereas in case of flaccid bulbar palsy, the voice sounds breathy. So that is the main difference between the spastic and the flaccid bulbar palsy. Dysarthria, which is common in both, but the characteristic feature is different. Next symptom, that is dysphagia, that is impaired chewing or the swallowing. So in case of an spastic bulbar palsy, which allows the liquid to pass through the larynx very easily, and in case of an flaccidity, so fluids may regurgitate upwards and the patient may regurgitate the fluids in the nose also, right? And sometimes nasal tone is also seen. Another two important clinical feature, that is the siluria and the pseudobulbar effect, which is also seen. Siluria, that is the drooling of saliva, and drooling of saliva, if it started at night, so at morning we see a wet pillow. And in the pseudobulbar effect, which is the pathological emotion control, so which is also seen. To understand the diagnosis of the ALS L scoreal criteria is there, which is there on your screen right now. Next comes, that is the disease course. So in the disease course, average duration, that is 27 to 43 months, and the death occurs usually in the 3 to 5 years, and the death occurs mainly due to the respiratory failure, as we have discussed the respiratory clinical features. Next thing is the prognosis. Prognosis of the ALS, which is very high correlation with the age. So a person who is diagnosed with the ALS at the age between 35 to 40 years or less than that, they have a very good prognosis than the person older than this age group. And next thing is the onset. So the person with the limb onset ALS, they have a very good prognosis than the person with the bulbar onset ALS. So this was all about the information of the ALS. I hope you like the way of presentation. If you like my videos and the content, so do like, share and subscribe this channel. Share these videos maximum so that one can understand the concept of the neuromedicine in a very simplified manner. Thank you so much. Thanks for watching the video till end.